My name is Paula Hanford. I'm the CEO of PSC Support, and I'm absolutely delighted to be joined this evening by Dr. Palak Trivedi. Those of you who joined us for our recent Information Day in Manchester will have had the pleasure of hearing Dr. Trivedi recently. So he was absolutely brilliant at that event. And he is one of the world's leading experts on PSC. So we're in very, very good hands. Dr. Trivedi is a consultant hepatologist at the Queen Elizabeth Hospital in Birmingham. He's the chair of the BASL Immune Special Interest Group. I have to read that. The Immune Special Interest Group and Chief Investigator for UK-PSC. And as always, I'm sure everybody here will join me in thanking Dr. Trivedi for giving up his time completely free of charge this evening to talk to us tonight. The title of this session is PSC Research, FARGO and the Microbiome. And Dr. Trivedi will open up the session by talking about the current landscape of microbiome therapies in PSC. And then there's going to be plenty of time for questions. So some of you have given me some questions beforehand, which is great, but please do put your questions in the chat, and we will take as many of those as we possibly can. As always on these sorts of events, Dr. Trivedi will not be able to give individual medical advice, but we'll answer the questions in the best possible way. So we've now got 87 people on the webinar, which is great. So welcome, Dr. Trivedi, and thank you so much for giving up your time tonight. We're really grateful, and I'll pass it over to you.
Thank you very much, and thank you all for giving up your time to listen to me talk about the microbiome in PSC, and for having me on this webinar. So I don't have any slides deliberately, and that's because previously when we've done sessions like this, the slides end up taking a lot of time. So I thought I'd just give a brief overview of, and because again, it's my personal view, it's not necessarily something that represents the view of broader individuals, but about the role of the microbiome in PSC, both in terms of its development, its progression, and where potential therapy or therapeutic avenues may go. So the reason that the microbiome, and I'm going to particularly focus on the gut microbiome here, although I will mention microbiome in other areas, but the reason that the gut microbiome has garnered interest in the liver disease world is because the close connection that the gut and the liver have to one another. When you are all sort of in your respective mother's wombs, your liver, your bile ducts, your gut are essentially one structure. And as you develop in utero to become human beings, the organs separate out and they start their journeys away from one another, but they're fundamentally made of the same grit. And that's why it's no surprise really that if an individual has some involvement of the gut in terms of inflammation, for example, a proportion of those individuals will develop inflammation and some form of injury to the liver, and vice versa. Now, of course, there are lots of people who have PSC that are on the call. In fact, the majority of you, I suspect, will be classified sort of as patients, with PSC, or have loved ones with PSC. And as many of you will appreciate, the liver is part of the picture. About 70–80% of people will also have some form of inflammation in their bowel. Some of you may even have had surgery on the bowel. And why do liver and bowel diseases occur so closely to sort of with one another if what I've just explained to you is something that's happened many years past? The microbiome is part of a bigger story. What we see is that the liver has most of its blood supply, about 70–80% of its blood supply, from the gut, perhaps slightly more in fact. And the liver does many functions, one of which is to make bile, which is delivered to the gut. So in turn, so blood goes into the liver, bile comes out of the liver. It delivers that bile to the bowel. And it does that through the bile ducts, which are the main site of injury in people with PSC. When we have people who have colitis, bowel inflammation, about 15–20% of people with inflammatory bowel disease will show some features of PSC if you were to scan them, even if liver tests are normal. And we now accept the fact that abnormal liver tests are not required to make a diagnosis of PSC. The fact that the gut and the liver are so closely associated, but in health and in disease, has had many investigators, myself included, to try and understand what is it about gut inflammation that sets off liver inflammation. Now, we have many more microbial cells in the body than we do human cells. And in fact, most of us will have a very diverse population of species within the bowel itself. And this consists of bacteria, fungi, viruses, and so on and so forth. But what we see in people with colitis alone is that the diversity of these organisms is somewhat reduced. It is not as rich and diverse an environment as it is in people without inflammatory bowel disease. And in people with liver diseases of any sort, PSC is no exception, the diversity shrinks even further. So if you've got colitis and if you've got liver disease, then the diversity of the gut microbiome sort of becomes more narrow. Now, I mentioned that that's common to all diseases. But in PSC specifically, there are some changes that have been studied in more depth. Now, that is because people who have inflammatory bowel disease with PSC have things like colonoscopies, which people with other liver diseases may not undergo because their bowel's not involved. What we found through looking at the microbiome in PSC beyond its diversity is that certain populations of bacteria in particular are upregulated and certain ones are downregulated. And that means that you have an abundance of certain species and a reduced abundance of others. Now, it's not just what the abundance of a particular species does, it's what does the function sort of relate to. And a lot of work looking at the what the functional consequences of these microbial changes is starting to unravel certain pathways around how does the gut bacteria and other species handle the bile that comes to it from the liver? How does it handle certain what we call amines that are produced by the bowel and from what we eat and drink every day? And because we see that the functional consequences of these particular changes in the gut are different in people with PSC compared to inflammatory bowel disease alone, and indeed compared to certain other liver diseases, we've started to explore them therapeutically. What can we do to change in a favorable way what happens to the gut microbiome? And we can do that in several different sort of ways. The easiest way that we can change what happens to the gut microbiome is with antibiotics. There are very few antibiotics that will not, I don't think there are any antibiotics that will not change what happens to the gut microbiome. And a lot of attention, particularly from our colleagues sort of in North America, has been on one particular antibiotic in vancomycin. Now, vancomycin is an antibiotic that has been around for decades, and it is very effective at treating a particular cause of infective diarrhea called Clostridium difficile. It is very poorly absorbed when taken by mouth, and for other indications that I won't go into, if we give it intravenously, none of it really gets to the gut. So it sticks in sort of a particular compartment where it's where it's given to. But in people with PSC, there were some studies from more than 10 years ago now that showed when people were given oral vancomycin without having infective diarrhea, their liver tests started to get better. And then more and more people started taking vancomycin just to see what happens. And there are now several people that I know of who have been on vancomycin for days, weeks, months, years, who have actually tolerated it very well. Their PSC has not progressed, and their liver blood tests have actually improved. What we now are in the stage of doing is trying to confirm these observations, because for any particular observation like this, you need to have a group of people who've taken a medicine, in this case vancomycin, and another group of people who have not taken that drug, and see what the differences in those two populations of people are. Some data from the children's hospitals in the United States try to do this, and there are some caveats to it, and they didn't really show a big difference in the long-term need for things like transplantation, etc. When people were taking vancomycin versus not. It was a short-term study. It was done with different preparations of vancomycin rather than one singular one like you would do in a proper clinical trial, but it did raise some eyebrows as to whether vancomycin was doing something. in our experience, and in those of the Children's Hospital and in those investigators elsewhere, what we find is that vancomycin is very effective at trying to reduce the amount of inflammation that people have in the colon. And when you do that, when you reduce the amount of inflammation in the colon, then yes, the liver blood tests do improve. And we would like to think that improvement, or at least normalization, of liver blood tests is associated with better long-term survival, which is what we all want. And we are starting to sort of unravel what it is about this particular antibiotic, or indeed other antibiotics, that helps the colitis improve when we can't pick up an infection there. And that's certainly work that we're doing in Birmingham. And there are some studies in a similar vein taking place around the world. The other way of changing the gut microbiome is by transplanting it. So we try to deplete your own gut microbiome in the best way that we can, or the safest way that we can. Now, when you have bowel preparation to clear all the bugs from the gut, all the stool from the gut, it is not an absolute 100% knockout. In fact, many of the gut bacteria and other organisms will still stay attached, but you will get a good sort of cleanse and a good clear out. And it's perhaps sort of the baseline, sort of to test any new intervention. And what we can then do is replace that with somebody else's gut microbiome. So we take the microbiome from somebody's stool, it is processed, filtered, homogenized, and it is looked for particular patterns. That we out of every 100 people who may want to donate stool for a stool transplant, only about 20 of them will actually pass the finish line, because we have such a rigorous screening process here in the UK. And we have done some studies in people with colitis alone, showing that also may be effective at helping people come off the medication, or improving the amount of inflammation, or reducing the amount of inflammation, I should say. And we are now doing a trial, the FARGO trial, which Paula mentioned, where we're comparing what the effects of giving stool transplantations are in people who've got colitis, or who've had had colitis before and have now got a pouch. And we hope to start recruiting people very soon. We're just waiting for our UK regulators to give us the green light to begin recruitment. So if anybody on the call is from the UK and interested in that study, then please reach out to PSC support, and they can put you in touch with us in Birmingham and the other trial sites if they're closer to you. And the last thing I just wanted to talk about in terms of our own microbiome research is for people with slightly more advanced liver disease. So the first two things I mentioned, at least in our early observations, they tend to be something more applicable to people with more early to moderate stage disease, rather than people with very advanced disease, i.e. cirrhosis and some problems associated with it. At that particular stage, it is our sort of understanding that changing the gut microbiome may not alter what happens to the disease overall, but it can help improve symptoms, and it may help reduce the likelihood of problems occurring over time, i.e. your liver losing function. And so we're just about to start a study here in the UK, our third study on gut microbiome that we're going to be doing in Birmingham and London, where a new device called CarbAlive, which is which are tiny little beads made of carbon, and they have got absorptive properties for certain toxins that are present in the gut. Now, it's biologically inert, doesn't get absorbed, but the toxins stick to it, and when somebody goes to the loo, these beads come out with all the toxins attached. And we are now testing this intervention for people with more advanced liver disease who are less likely to benefit from things like vancomycin and fecal transplant. Now, again, just to finish off, the gut microbiome is one part of the puzzle. There are other ways that we are also looking at to try and modify what's going on in the gut to help improve what's going on in the liver, targeting certain proteins. Certain types of bowel surgery, in fact, have also been shown to be protective in terms of PSC progressing, and certainly if people have a liver transplant, to reduce the risk of PSC coming back. But I won't go into those strategies unless I'm asked questions about them. But I thought I'd give you a whistle-stop tour about the gut microbiome and so on. And I'm happy to take any questions.
Oh, thank you so much. We have quite a few questions. I've had some questions beforehand as well. I think there's a few questions that are general questions, so I hope you don't mind taking those too.
Of course, yeah.
We've got some people with their hands raised, but if you could ask your questions in the box, that would be fantastic. So I'm going to ask a question I've had previous to the event. And I think you've touched on this, and I think you've answered it, but I'm going to ask the question anyway. Can people have their colon removed and have a pouch and still take part in the FARGO trial?
The short answer is yes, you can, but there would be other things, category that will also need to be fulfilled. So for example, you will, if you have had a liver transplant, unfortunately, you will not be able to take part in the FARGO trial. There will be other trials, I am sure, emerging in that domain. And if you have evidence of cirrhosis, which is sort of liver scarring that's unlikely to be reversible, then unfortunately you cannot take part in the FARGO trial either. But yes, if you've had a pouch, then yes, you can take part. Your liver blood tests and other things will also be screened for eligibility, but yes, you can take part.
Fantastic. And again, I think you mentioned this, but maybe you could go into some detail. Is the FARGO trial only happening in Birmingham?
No, so it will happen in London. There'll be 3 sites in London. There'll be 1 site in Birmingham, 1 site in Oxford, and 1 site in Norfolk, Norwich.
And what are the criteria to take part in the study in the UK?
So the criteria in the UK are you have to have elevated liver blood tests beyond a certain threshold. You cannot have evidence of cirrhosis to take part in the study. You have to have had inflammation in your colon, so either colitis, ulcerative colitis, Crohn's colitis, or if you had colitis and you had your large bowel removed or operated on and have a pouch, that is also acceptable. And if you are on certain types of antibiotics, you will need to have stopped them for a good few weeks. At the moment, sort of, we're trying to negotiate 12 to 8 weeks to reduce it to 8 weeks, but at the moment it's still 12 weeks. You would have to have off antibiotics to take part in that study.
Okay, great. Somebody comments here, I suffer with PSC and ulcerative colitis and were diagnosed at Birmingham last Monday. They mentioned fecal transplant during that. It's something I would be interested in finding more about. So that was a very recent, somebody with a very recent diagnosis. Next question, would a gallbladder cancer diagnosis disqualify a patient from taking part in the trial?
So it wouldn't disqualify, it wouldn't disqualify you from taking part in the trial if it's a previous diagnosis. It has to be at least a year, although some of the regulators may want it to be more, has to be at least a year since that gallbladder cancer was treated, i.e. the gallbladder removed. But no, it would not disqualify you from taking part.
Fantastic. Another question, what will the trial entail practically for the patients and how many times will the transplant be made?
So the trial itself will last for 48 weeks. The fecal transplants will be administered at the first one at the time of your colonoscopy, and the subsequent 7 doses will be administered once a week over a total period of 8 weeks. So first one colonoscopy, and then once weekly for the next 7 weeks. The further doses that we're going to be giving for the fecal transplant will be given via enema. So they will be and all of these will be a day case. None of them will require hospital admission.
Fabulous. And another question about a sort of logistics of the trial. When is the trial taking place? The recruitment is this summer. Is that correct?
Well, yes, we were hoping to be open now, actually. So Easter was what I had entailed. Sadly, timelines outside of my control, and those people in our trial team have delayed the start of the study, and that is very much a regulatory issue. But yes, we are hopeful sort of to recruit over the summer. The reason I mention I say summer as a broad term rather than a particular month is based on other studies that I'm involved with and the delays that have happened with them before activation. I suspect it will still be a good 2 to 3 months before we can open.
Somebody here says my consultant doesn't seem very interested in proposing me to take part in clinical trials. That's something that we do feel strongly about actually at PSC Support. How do I get considered without his help?
So it's a very good question. So you will need a referral to me or one of my colleagues who is doing a trial, and that can either come from your consultant, but if they're not interested, as you say, from your GP. so one of the two things, one of you two can do that. And if you're really not winning, and you contact PSC support, then PSC, and you provide consent for your information to be passed on, then PSC support can highlight it to me, and I can make contact with your consultant if I'm very happy to do that. One thing I will say, though, is that whilst clinical trials should be considered for everybody, there is a bit of an asterisk to it. So there are some people who have PSC, which is actually very slow to progress, or does not really progress, and is developed and has just stayed the same. And I wish I wish everybody had that sort of type of PSC. It's sort of in the absence of a cure. And those people may be those with what we call small duct PSC. So that's PSC where the MRI scans are completely normal, but you can only really pick it up on a biopsy. And there are other people who have completely normal liver tests, as I mentioned at the start, who may not be eligible for current clinical trials, but there will be other ones available in future. And so if you feel that you would like to take part, and your doctor has not given you guidance as to why you shouldn't, or why they're not keen, and you just want to have a chat, then by all means do get in touch.
Great. Somebody here says, great talk, thank you. Do you think we will eventually have gut microbiota cocktails tailored to us individually? There's a lot of talk about bespoke medical treatments. So what about that scenario?
Yeah, I mean, absolutely. I think that we have to prove that changing the gut microbiome is going to be beneficial, and the way through fecal transplant and other ways. We are at the start of that journey. It may not. I know that's not what everybody wants to hear, but we are very much at the start of that journey. And does changing it lead to a long-term, meaningful benefit, not just your liver blood test improved? Is the long-term outlook in people who've had the gut microbiome changed in a particular way better than the long-term outlook for those people who had not undergone a change to their gut microbiome? And then we can try to identify what is it about the change in microbiome. Is it a particular bug, or is it changing a function of a particular bug that has made the difference? We had a very nice colleague of ours visiting us from Yale University 2 weeks ago, Professor David Assis, and the Yale group are doing a very nice study where they're giving a particular type of virus called a phage, which changes the way that bacteria work. So you actually give a virus that is engineered to alter the way that certain bacteria function in the gut, and they're using that technology in PSC studies in Yale. So if any of you from North America who are on the call live near Connecticut or New York, that may be an avenue that you may wish to explore in their studies. But to get back to the question, what we would need to do to get to that stage, we would need a rapid, high throughput way, almost like a point of care way, where you can provide your stool or your biopsies from your colon. So this is what your gut microbiome is doing. So that's a bit like a 23andMe. This is what it is, but it won't necessarily tell you what it means yet. Finding out what it means will then need fancy computer programs and AI style algorithms to say, right, this is how it all links together. It's not just that certain things are upregulated and downregulated, but altogether, what does it mean? And then it will need to identify a corrective pathway as to what needs to change in that particular pool of gut microbiota, and how you do it. So there are several steps that we need to get to. I suspect it will move quicker than it has in recent years, because AI technologies have expanded at furious pace. I mean, just look at ChatGPT, for example, and even in some of our studies using vancomycin to treat people who have PSC-associated colitis, we've identified certain types of pathways which may hold the answer as to what makes as to what goes up and what goes down in people with very active inflammation in the bowel and very high liver blood tests, and to people who actually improve their liver bloods and have no inflammation in the bowel. And if we're able to do that just by changing the gut microbiome or a particular pathway, then that's treating both elements of PSC with one stone.
Great. I'm trying to focus these questions on the trial on the microbiome, and then we'll take the general questions once I've done that. So another question, and I suspect this person is outside of the UK because their question is, would you accept a foreigner? And I presume it means on the FARGO trial.
That's a very good question. So yes, you would need to be registered with a GP in the UK, I'm afraid, to take part in the FARGO study. There may be other fecal transplant trials taking part elsewhere. We do not exclude people who are, say, private practice sort of paying individuals. That would need to be negotiated with whichever hospital you choose to go to, as to if you want to take part in the study. So it's not an absolute no, but you would need to be registered here and very likely pay a private fee to the National Health Service, both to the GP and to the hospital to take part.
Okay. I actually thought it would be a no, so that's very interesting. I wasn't quite sure that would be the case. Can I take part if I have an ileostomy?
In the FARGO trial?
Yes, I think that's the question.
So at the moment, no. So sadly not. You would not be able to take part in it because you wouldn't have a colon or any colonic remnant for us to administer the gut microbiota transplant to. One of the things I will say to people who've got an ileostomy, though, and it's not an absolute rule, but we are starting to learn the fact that both people who've got PSC who have not had a transplant but who have bowel surgery and have got an ileostomy, their PSC tends to progress much slower. And in fact, some early data from the Netherlands suggests that the risk of things like liver transplantation and other complications from arising from PSC are much lower in people who've had an ileostomy compared to those with a pouch, or who've still got the colon and the colitis is active. And we have certainly shown in the UK that in people who have had a liver transplant who've got an ileostomy, they have a very low risk of getting PSC or coming back or other complications in their liver. But the complications are sort of in the liver that we see, sort of that 20-30% risk of recurrence. And I'll be very open and transparent with that is the risk that we see over a 10 to 20 year period after transplantation. That does persist in people who have got a pouch and people who have not had their colon removed because of colitis. So ileostomy in some ways is actually a protective intervention, and we're learning more about that.
Okay, thank you for that. Somebody here is due their annual colonoscopy in the middle of next month, and they're asking, will this exclude me from taking part in the trial upcoming in the summer?
Yes, it's a very good question. So it wouldn't exclude you as such. But you would need to have another colonoscopy. So if you really wanted to do the study, it would mean having 2 colonoscopies in quick succession. I would not sort of for the life of me say you need to delay standard of care in any way, shape or form. But our current guidelines sort of state, annual colonoscopy if you have colitis, defined as a colonoscopy every 1 to 2 years. So if you've had a colonoscopy 12 months ago, or in this person's case 11 months ago, and you do it next month, then there is no, then you can, within the realms of standard of care, delay that colonoscopy unless of course you're having active symptoms, in which case I wouldn't delay it and I would go ahead as planned.
Okay, thank you for that. Next question. This is a really good question, actually, I think. If a participant gets benefits through FARGO, what happens then? Can they continue with the therapy?
Yes. Yeah. So it's an early phase 2 trial. So trials are phases, phase 1, 2, and 3. Phase 2 is sort of the middle ground, which is what this study is. We don't currently have the funding for you to carry on receiving fecal transplants thereafter. We don't have that. We just haven't got the money to do that at the moment. All these trials we have to apply to charity funding or public sector Department of Health type funding for them to give it to us. So at the moment, we're only funded to do the study in 58 individuals over the course of 48 weeks. That said, if we do see positive results, then we will have a very strong argument to continue giving fecal transplants to people, and that would be almost like, yes, an open label intervention. That means anybody who wants it, who took part in the trial, could carry on getting it, but also to do a much larger study to make it to prove that it is giving benefit, but that proof of early benefit needs to be shown in the majority of people in the study rather than just 1 or 2 individuals, I'm afraid.
Yeah. Okay. So this question is about prebiotic diets, which that question around prebiotic diets do come up fairly frequently. And the question is this: if there are recorded positive results linked to certain microbes in the gut, could this also be targeted with a selective prebiotic diet?
Yeah, okay, yeah, excellent question. So there are very few prebiotic studies in people with PSC. There are slightly more in people with colitis. Sadly, with the small exception of one probiotic combination in people with pouches, the data have not been positive. So we have not seen benefit from prebiotics outside of one particular prebiotic called VSL3 in people who have pouchitis. That's inflammation of a pouch following bowel surgery. But yes, there is no positive data to say that it will lead to benefit. And in fact, some people who have autoimmune diseases, and we would consider PSC and at least an immune-mediated, if not a proper autoimmune disease, then some of the prebiotics contain things like enterococcus, that's a particular bacteria, which has been shown in animal models to lead to autoimmunity. So we would not want people taking prebiotics without checking with a doctor, because if they've got things like enterococcus, then theoretically that may make things worse. I'm not saying it absolutely will make things worse, but there is certainly evidence in animals that it may do. So the short answer is no, I can't advocate for prebiotics outside of people who've got pouches, and that's specifically to treat the pouch. There is no data that I'm aware of, at least, that a prebiotic will help with PSC in any way, and some of them theoretically could cause harm.
You mentioned that, and there's a question right at the beginning about is PSC an autoimmune disease? And you mentioned there that it's certainly an immune-mediated disease. What's the difference?
Yeah, so an autoimmune disease, I mean, there is no strict definition for what an autoimmune disease is. An autoimmune is, but there are certain criteria that we look for. So, for example, you have to have a particular antibody, so a protein in the circulating in the blood that is directed towards another protein in an organ. So, for example, people who've got autoimmune thyroid diseases, they will have antibodies directed against certain types of thyroid proteins. People who have type 1 diabetes, they have certain antibodies directed against cells in the pancreas, and so on and so forth. We have not yet found a disease-specific antibody in people with PSC. Yes, we do see antibodies, but they can be found in other conditions as well. There is no real disease-specific antibodies. There are in some other autoimmune liver diseases like PBC, primary biliary cholangitis, where we do see a disease-specific antibody. So because PSC lacks that particular hallmark, it's people consider it's less likely to be a typical autoimmune disease. The second thing is that most autoimmune diseases tend to increase in prevalence, increase in frequency in older individuals. But in people with PSC, most individuals are diagnosed usually between the ages of 30 to 50. Some are diagnosed very young as children, and very few people, or much less commonly, people are diagnosed in older age. And in fact, older age is one of those things where PSC is less likely to progress even when you get it. So that's the other thing that is less common. And the other thing that makes PSC a slightly less typical autoimmune disease is the fact that the autoimmune diseases tend to occur more commonly in women, but PSC tends to occur more commonly in men. So it's atypical in those respects. But when you look at a liver specimen and you look at the injury, it is all driven by immune cells that your own body has developed against something, attacking your bile ducts and liver. It is all, the genetics tells us that there is a huge overlap between certain genetic risk factors with other autoimmune diseases like celiac disease, for instance. So there are lots of genetic signatures that are very common to other autoimmune diseases that we see in people with PSC. And one of the biggest standout signals is a particular protein that presents what we call antigens from your body's own self to the immune system. And when we see that particular genetic signal saying, right, your body is showing itself saying this is a foreign invader, whereas actually it's something that you're born with, that is again a genetic signal that we see in people with autoimmune disease. So there are certain sort of characteristics that would make anybody say, yes, this is typically autoimmune, principally the genetics, the way that the disease looks, and the fact that it recurs in people after transplantation. But there are certain things that make it slightly less typical, slightly atypical to other more conventional autoimmune diseases. The fact that it affects men more commonly than women, the fact that it affects younger people more so than those people of older age, and most importantly, perhaps it doesn't respond to things that dampen the immune system. But that is less of a hard and fast rule, because things like thyroid disease and celiac disease don't respond to that either.
Thank you for that.
Yeah.
So a bit of a question about the logistics of the trial, I think, really. How is the transplant carried out, and what does the transplant consist of?
So we will have a pool of suitable donors who've got a very clean medical history and a clean family medical history. So no family history of things like colon cancer or inflammatory diseases. They have to have had a regular bowel habit for most, if not all, of their life, rather than it being infrequent, with normal stool habit. They can't be a smoker. They have to have certain dietary restrictions, and then their stool is screened for certain pathogens, and then that particular individual's stool is screened for certain favourable characteristics, i.e., diversity. It has to be a very broad-reaching microbiome. Then their stool is then processed, ultrafiltered in our laboratory, and stored ready for use. Meanwhile, individuals who decide to take part in this particular study, they will then volunteer themselves. We will screen them against a checklist to make sure that they're eligible, and we will then call them in for a colonoscopy. They would have had their bowel prep, they would have consented to take part, and they will either get a fecal transplant or what we call a placebo. So that's an inactive sort of equivalent, and you will not know which one you're getting. It's sort of, the person who is administering it will, but you will not see that individual again in your sort of trial visits. And in the following weeks, you will have enemas given to you once a week by a different person for a total of 8 weeks. And at the end of 48 weeks, sort of plus or minus 4 weeks, so that'll make it a year, we will see what's happened to your liver blood tests, as well as other things such as markers of liver scarring, your quality of life, and if you've had active colitis, your colitis symptoms. So those things are sort of will also be looked at, and that's pretty much in a nutshell what the trial would involve from the donor side and you as the potential participant in the study.
Fabulous, thank you for that. You've touched on answering this question, I think, just now, but would patients with PSC but without colitis be considered for the FARGO trial?
Sadly not. It's mainly because most of the work that we have done to understand the links between the gut and the liver have been done in people with PSC and colitis. Now, we do see the same change in the gut microbiome, even if you don't have colitis, and it may be that you get colitis when you're older. But because of the phase that the trial is in, we wanted broadly speaking, a similar population, and we either had to choose between, for example, people who've had pouches but had their colon removed, or those who've still got a colon but don't have inflammation in it. If we were too broad with our entry criteria and we were just shy of seeing a significant signal in the study, that would be the end of the program. So for this part, no, I'm afraid. Yeah. But in future studies, we can broaden the reach of the study.
Okay, and another question about the logistics, if you like. How will each, well, it's not really logistics, but I'm going to just read the question. How will each case patient on the FARGO trial be evaluated? So it's an evaluation question. Will there be shotgun metagenomics? Could you explain what that means as well? Some such testing before and after?
So it is not just shotgun metagenomics that we're doing. So there will also be some deep sequencing of the microbial species. Now, this essentially is in an effort to see how deep the changes in the gut microbiome go. So I won't sort of, I mean, I can go into specifics, but sort of, and I'm very happy to sort of communicate with the individuals who ask the questions. But yes, we are doing shotgun metagenomics as a basic. Well, there's an even more basic signal than that, what we call 16S, which is sort of the very easiest way you can sort of tell what's changed in the gut microbiota. Then we've got sort of shotgun metagenomics, and then we've got sort of deep sequencing, sort of which we're also going to be doing with individual species, just to see the depth at which the microbiota have changed. So just as a parallel, if you have say the human race of Earth, we're all very diverse and different, and that's perhaps just telling us what is the most, I mean, what we believe, what is the most intelligent form of life on Earth. If you were an alien race was to peek in with 16S, they'll say, right, human beings, okay. And then if you and then the next level of depth is saying, okay, what is sort of the most, I don't know, the most prevalent religion, and they'll say, right, Christianity, second most, maybe Islam, third of, I'm just guessing, I have no idea what it is. The third maybe Hindu, like me, and so on and so forth. You sort of get to that, and then you say, right, okay, even in say Christianity, I want to go even further. What's Protestant, what's sort of Church of England, what's Catholic, that sort of depth. So we have series of depth that we can go to when we're identifying certain microbial species. So we say, right, these are the bacteria, these are the fungi. Then they have certain families and subfamilies and subfamilies, and shotgun metagenomics is a layer at which we can actually detect the type of species, the depth, and so on and so forth. So yes, we will be doing that. Is the short answer.
Thanks. So we've got 15 minutes left, and I'm gonna take some of the more generic questions that people have asked. We had one prior to starting, and that was about a fibroscan. What are the benefits? So there's three questions linked to the fibroscan. What are the benefits of the fibroscan? Do you get similar information to an MRCP or different? And how frequently should you have one?
Yeah, excellent question. I mean, maybe we should. I mean, one of our webinars could be about the different, risk tools that we use. Okay, right. So for those of you people who don't know what a fibroscan is, it's like an ultrasound machine, but rather than giving me a picture of what your liver and bile ducts look like, the fibroscanner gives me a number, how stiff your liver actually is, and that level of stiffness in the liver is, for most people, will represent how much scar tissue there is, how close you are to cirrhosis or how close you are to normal. There are other things that can increase the liver stiffness though. So if you've got very bad strictures or narrowings in the bile ducts, that can also lead to back pressure in the bile ducts and a high fibroscore reading. If you've got active colitis or infection or inflammation, cholangitis, flaring, that can also lead to increased levels of stiffness in the liver. And if you've started off as, some people start off with autoimmune hepatitis as their label, and then later on in life they can evolve to developing PSC. If you've still got lots of inflammation, that can also lead to elevated fibroscore values. So for most people, it's stiffness and scarring. The stiffness means the level of scarring, or fibrosis as our medical jargon term is, and how close you are to developing cirrhosis or how close you are to normal. But there are some people which can have increased readings for other reasons, and they're the less common group. Now, we use it as part of our tool to see whether your PSC is progressing as a disease, and also just to help inform us in a broad sense, what your risk is or will be for things like a liver transplant in later life. But it is part of the picture. So when I see somebody with PSC in my clinic, I will go on what their symptoms are, and particularly do they have very bad itching, and also things like recurrent infections, recurrent cholangitis. The reason I mention those two symptoms in particular, because those two symptoms are ones which often need to liver transplantation, even without cirrhosis, even without scarring of the liver and loss of function. The other thing that I look at is going to be your blood tests. So how well is your liver performing? Is it passing its MOT? What's its function? The third thing is going to be the MRI scan, so that the MRCP. So that's going to tell me what the bile ducts, what the tubes are doing, how and if there are particular narrowings that may benefit from a procedure to open them up. And if I see the level of narrowing going up, it's sort of worse and worse every year, symptoms getting worse, blood tests getting worse, I can speak to that individual and say, right, actually, I think your PSC is getting worse. This is the probability or estimate that you're going to need a liver transplant in the next 5 years or 10 years and so on. The FibroScan is the fourth part in that jigsaw puzzle. Now, for most people, as I said at the start of the question, answering that question, it tells me how much scar tissue has built up in the liver itself, and that's what's making the liver stiff. So the MRI scan does not tell me that. The MRCP does not tell me that. That tells me about the bile ducts that drain from the liver. The FibroScan tells me what's happened to that liver as a result of that, the background stiffness and scarring, and the magnitude of scarring and how your liver functions as well as your symptoms are what determines the need for transplantation in PSC. The bile ducts and the changes in the bile ducts are something that happens usually sort of early on before liver stiffness develops.
Thank you very much for that. Question here, what advice do you have for someone with high cholesterol and PSC?
So high cholesterol is common in people who've got problems with the bile ducts. It's the way that bile is handled and how cholesterol is incorporated into bile. The finding of high cholesterol is actually quite common in people with PSC and other bile duct sort of issues. If that individual has a high cholesterol in isolation, and what I mean by isolation, I mean without any other risk factor for heart disease or strokes, such as smoking, high blood pressure, diabetes, obesity, a strong family history of heart disease at an early age, below the age of 60 years old. If they don't have any of those things, I would just monitor the cholesterol. I would not necessarily treat it. But if any of those other risk factors are present, then I would advise an anti-cholesterol drug, or I'd get their GP to discuss them. There are some anti-cholesterol drugs which are actually being trialed in people with PSC to help improve symptoms and liver blood tests. So I would often speak to them about that and say, look, would you want to take part in a trial of this agent? Not because you've got high cholesterol, but because it's likely you will go on an anti-cholesterol agent in later life. Why not go into this trial that gives you that drug, because it might have other benefits to your PSC.
Okay, thank you. Question about cholangitis attacks. Do they happen rapidly or does it build up over time? And what are the signs of an attack?
So cholangitis attacks or episodes are thought to represent infection in the bile ducts. So PSC is a condition where the bile ducts become narrow and squeezed, so bile cannot flow out properly. And as with any stagnant body of fluid in nature, be that in your liver and a bile duct, or even if you've got a blocked sink at home, that fluid can fester and become infected. And whether it's infection or just inflammation, we don't know, but people present with features of an infection, usually pain that sort of comes on, and it can be sudden onset. When I say sudden, i.e. you can wake up with it one day or it develops over the course of a day. It is not a sudden pain like when you've pulled a muscle or when you had a sudden trauma or something. It is something that creeps on over the course of a day, but that sort of onset, often people with sort of, with PSC, as well as the pain, can have other symptoms such as worsening or new onset of itching, particularly in the palms of the hands or soles of the feet. And there are very few other itchy skin conditions that cause itch in those areas. People can become jaundiced, so their skin and eyes can become a bit yellow, and they may develop a fever. Now, you don't have to have all of these symptoms. And the only real way of knowing whether it's a cholangitis attack is, yes, when you've got those symptoms and your liver bloods become deranged, but often it's not practical to have a blood test each and every single time you develop a flare in those symptoms. So we do treat cholangitis attacks pragmatically. And what we advise is that if you have these symptoms and you've had an episode of confirmed cholangitis, or your doctor has said, actually, I think that the symptoms you're presenting are very much like cholangitis, we will give you antibiotics. And if you develop them again, we will give you more antibiotics, to the point we'll say, actually, we know what this is. They're presenting in this particular way. And if you get better with it, these particular antibiotics, we will give you a pack to keep with you at home. And when you have a further attack, email or phone us, and we will say, yes, take your antibiotic course. And if you're not improving on them or you're getting worse, get in touch again, because we may require different ones or need you to come in hospital. There is not one particular definition of what a cholangitis attack is. What I've sort of described is a reasonable, broadly held view by people who look after individuals with PSC. Fever, pain, jaundice, itching are some of the features, together with abnormal liver blood tests, but you don't have to have all of them. And often you need sort of an experienced PSC physician to talk to you about these symptoms, and then you can sort of discuss. And sometimes I don't know if it is a cholangitis attack or not, and I've given people antibiotics just to see if they get better, because I just want to make people feel better. And so it's not always, I'm not always going to be right about them. But sort of as long as I'm able to sort of offer that help to see if people get better, then that's the best I can do at the moment.
Okay, thank you for that. You touched earlier on Vancomycin, and there's a question, two-part question actually, about Vancomycin. The first is, if we have missed the Vancomycin trial, can we request our clinician to prescribe it? And I'll take the second part of the question as well. And then if we take it, will we still be covered by insurance?
Oh, excellent question. So, I mean, in the UK, we have a publicly funded healthcare system. So unless you're opting to take it privately, which I'll come back to in a second, the insurance element is not an issue. Healthcare is free here. Whether you can still take vancomycin or not, it really depends on where you are and who you're seeing. In my practice, if I've got somebody with difficult to treat colitis associated with, so I can see your son in the background, I think, Paula, just shaking his head, I think. It's all right, it's making a BBC cameo appearance.
Sorry about that.
No, that's all right. Nice to see him. So if somebody has PSC and has got difficult to treat colitis or colitis that's flaring, I use it to treat, sort of to get that person's colitis under control. I do not offer it in my practice for people just to improve their liver blood tests, sort of alone, because I have not seen it work in that context. And there may be others who elsewhere who have seen it improve. So I still offer it as what we call an off-label, off-patent medication to treat PSC-associated colitis. So yes, you can get it. Other doctors may be more offer it more liberally and say, because we don't have a definitive licensed treatment, you can take it, and if it works, it works. If it doesn't work, we'll just stop it, and it's not, and it doesn't really matter. So other doctors offer it sort of in a different way. Now, if you're seeing me for private practice I mean, I don't do private practice at the moment, sort of here, but if you're seeing a private physician, then yes, you can take it. Now, whether it's covered by insurance or not in the UK, I don't know is the answer. That is something that I would have to explore with private healthcare providers here. I genuinely do not know what the situation is like in, say, India, North America, and other continents and countries regarding the availability of vancomycin and reimbursement, I'm afraid.
Okay, there's a question about another drug, the role of UDCA in PSC patients. Do you recommend it?
So say that again. So you just my Zoom just paused. Sorry,
the role of UDCA in PSC patients, do you recommend it, is the question.
The short answer is no, I do not. So UDCA, or ursodeoxycholic acid, has worked wonders for other liver diseases, including those involving the bile duct. So it is standard of care and saves lives in people who've got primary biliary cholangitis, which is a different disease. Because it worked in that condition, people started using this medication to see whether it helps bile flow better. And there is certainly data from laboratory studies to show that it makes the bile less acid, and it may reduce the immune attack sort of on the bile ducts. That is in labs, lab data at least. But certainly all the studies that have been done with ursodeoxycholic acid in big trials, and even sort of the studies in the general population outside of trials, they've all been fraught with some sort of caveat. The vast majority show no benefit. There is no improvement in long-term survival. There is no reduced need for people needing a liver transplantation or developing cancer associated with PSC. if they're taking urso versus not. That is the overarching summary. You will certainly find one study here or one study there that has been done in a certain way where there is some benefit from taking ursodeoxycholic acid at a particular dosage, but overwhelmingly the lion's share of studies do not show that there is benefit even if taken at high doses. And in fact, if you take it at ultra high doses, like say 28 to 30 milligrams per kilogram of your body weight, it may actually be harmful. At lower doses, there is some data to show that it may improve liver blood tests, but that's all it really does. Yeah. And if people have been started on ursodeoxycholic acid and your bloods have improved or normalized, and you feel strongly about staying on it, I have no problem with that, and none of my colleagues will either. We don't push very hard to stop it, but I do not start ursodeoxycholic acid as a new drug in anybody with PSC.
Thank you. That question does arise quite a bit in some of these sessions. I'm going to just take the last question. We've got a minute left, actually.
Sure.
Is PSC genetically linked? I have been diagnosed, and my sister was diagnosed 11 years ago, says the poster.
Okay. Yes. So it's an excellent question. So it is. So is it genetically linked? Is the question. So the short answer is it is not inherited. So if somebody has, if somebody has it, you are not definitely going to pass it on to your children. It is not something like blue eyes and red hair that you will definitely pass on, nor is it something like cystic fibrosis, wherein where you can identify certain genetic patterns. But there is a genetic risk associated with blood relatives. So what we see is that the risk is more than tenfold for your sibling or your child of getting PSC or colitis if you've got it. So that's a risk that's greater than, say, your next door neighbor or your partner who is not going to be blood related to you. So there is certainly an increased risk of getting PSC or colitis if you've got it if your siblings or parents have got it, but it is not something that is going to be inherited with 100% certainty.
Okay, thank you. Thank you so much for answering all those questions. There was a question about can people get this recording, and we are recording the session. And it will be available on social media. We'll put the link on social media to our YouTube channel, so that will be available very soon. Thank you so much, Dr. Trivedi, for answering all those questions in such a brilliant way, and for joining us tonight. And I'm sure you will join us in the future as well.
Yeah, very happy to do so.
Thank you, and thanks very much for everyone who's taken part in this session. I think at the height we had 98 people on the webinar, which was really good, and for asking such great questions as well. Some really excellent questions. I won't keep anybody much longer, but just to say that the next Ask the Expert session is specifically around waiting for a transplant. So I know that'll be a very popular session as well, and it's with Dr. James Ferguson at 7 p.m. on the 12th of April. But thanks again, Dr. Trivedi. Thanks ever so much, everyone, for joining us. And we hope you can join us at the next session as well.
Thank you.
Bye.
Cheers. Bye. Bye.